Hello, everybody. Welcome to the 25th live stream. Dr. Jemsek and I are going to be doing part 2 of sleep, a big topic for us here at the Jemsek Specialty Clinic. We first want to start by saying that as a lot of our viewers for this live stream are not our personal patients, if you do have issues with sleep, need to get any prescribed medications or any procedures or anything like that done, you need to be seeing your local practitioners or providers. So we wanted to start this live stream off by going over some of the basics again. There were a lot of questions last live stream about some of the core concepts of sleep and the core issues that come up with sleep. So we wanted to touch on those again kind of at the beginning of this live stream. We think it'll help with some of the repeated questions that are really good ones. Dr. Jemsek and I wanted to start with the first question, which is going over the different phases of sleep. Dr. Jemsek?
Good morning, everyone. I'm very pleased to be doing a 25th live stream, and thank you very much for following us. So just basically there are 4 stages of sleep, N1, N2, N3, and N4. The first 3 phases are non-REM, so that's not rapid eye movement. And the last stage is rapid eye movement, which is, of course, when we sleep. Stage 1 is only a few minutes. It's light sleep. It's the sort of sleep that you can be awakened of, but just by a touch or a sound, but only lasts a few minutes. Stage 2 is a deeper sleep. It's a little bit harder to be awakened, and it lasts 30 minutes to 60 minutes. Stage 3 is deep sleep, which is characterized by delta waves. At that time, the brain is very quiet, and if you listen to TED's talks, which I would recommend you do, you'll learn that that's when the brain is able to detoxify, because brain produces toxic chemicals just like any other organ, such as chenolytic acid or oxalinic acid. And we think what happens is that there's dilatation of the veins that populate the brain, and they mix with the CSF, the cerebral spinal fluid, and that allows the release of toxins into the body and then into the waste. There are no lymphatic systems in the brain except for a very tiny cluster of lymphatics at the top of our brain, whereas the rest of the body has the lymphatic system to help drain these toxins. So here's the thing. If you don't drain the toxins, if you don't get deep sleep, then you carry those toxins over into the next day. And that's not a good thing. The 4th stage is rapid eye movement, which is our sleep cycle. Generally, there's 5 to 7 cycles. They get longer as the night goes on. Sometimes they're perturbed. So people ask, what's more important? What stage of sleep is more important? Well, they're all important. And light sleep, intermingles with deep REM, and so it's a combination of that for the last portion of our sleep. So if a sleep cycle is 8 hours, the last 4 hours we're in REM sleep and light sleep. And people ask, well, what does REM sleep do? It's hard to get an answer. Sleep is a very complicated subject. But REM sleep, without REM sleep, there are studies showing that it promotes neurodegeneration. So I guess I'm saying, and what Rachel will say, is that sleep is very, very important. And of course, in our Lyme borreliosis complex population, we commonly see, I would say the majority of patients have some sort of sleep disorder. So we'll talk about how we approach that. Rachel?
Yeah, so we many times approach sleep as one of the top questions when patients follow up with us. Our patients joke that we ask very similar questions with each visit, and it's to touch on, stability of sleep, stability of pain, stability of gut health, etc. But with sleep, we approach with the same questions to help us to understand what is causing disordered sleep. So the first approach to that would be to ask the patient, are you having any trouble initiating sleep or falling asleep, or are you having any difficulty staying asleep? And there are a lot of different things that can affect these 2 areas. I'm going to touch on a couple of them and have Dr. Jemsek maybe expand upon them, but we see patients have issues with getting up to go to the bathroom at nighttime, snoring, having potential apneic episodes where they stop breathing, having vivid dreams or nightmares, having night sweats, pain, hypogonic activity, which is a type of seizure, restlessness, busy brain, and a lot of these can be present all at the same time, or a patient can just have one of these issues, but it can cause really big issues for their ability to stay asleep and get efficient sleep.
Thank you, Rachel. So yeah, that's our approach. Do you have trouble getting into sleep? And do you have trouble staying asleep? Some people it's one or the other, or some people it's both. And we go through a very simple, so we actually ask people about sleep almost every visit. Well, if I'm tired, how are you sleeping? Because sleep is the best herbal, if you will. It's the best medicine, deep sleep and REM sleep. And so when somebody says they're tired, you have to distinguish between, well, am I tired or am I sleepy? Or is it both? Sleep is so important in terms of restorative properties to the brain. And as Rachel said, we go through that in a very specific way. To go back to stage 3 and stage 4, which is delta sleep and REM sleep, they should occupy each about 20% of the nighttime sleep. So if you're sleeping 8 hours, we're talking about 90 to 100 minutes of deep sleep. More is better, and we're talking about 90 to 100 minutes of REM sleep with several cycles. Again, if patients have disrupted sleep, is it getting off to sleep? For example, some people will say, no, I have no trouble getting off to sleep, but I wake up. What do you wake up? What wakes you up? And that's very important to know. Is it restlessness? Are you moving and kicking covers all over the place? Are you choking in your sleep? Are you up and down to the bathroom? Are you having vivid dreams and nightmares? So when you get up to down to the bathroom, for example, that's a pretty easy one, because Lyme, of course, affects the hypothalamic pituitary axis in a big way. It's a very vascular region. And the hypothalamus, which is the upper area of the limbic system, and the pituitary control so much of what we do in terms of our body functions, including sleep, including appetite. And if you're having issues with sleep, we need to know if the hormones are coming out. So in regards to excessive urination, you're not getting vasopressin, which is a hormone from the posterior pituitary, and its job, as far as we know, is to enhance water resorption by the renal tubule. If that doesn't happen, the water goes as urine into the bladder, and the bladder gets full. So patients think we ask silly questions like, if you get up twice at night, are you having a full bladder or are you having a squirt? And if you're having a squirt, that's more of a neurologic thing with the sacral plexus. But if you're having a full bladder, and you can have both, and if you're having a full bladder and you're getting up more than twice, you're interrupting your sleep cycle. You're fracturing your delta sleep and your REM sleep, but delta sleep in particular. And that is not, so we're all about getting good sleep. So we provide the hormone to replace what's missing, and eventually the pituitary will repair and solve that problem. Have I forgotten any of the major
we wanted to we wanted to talk a little bit too in regards to disordered sleep with the sleepwalking, sleep talking, vivid dreams and nightmares. And you had touched on some articles that one of our researchers had found in regards to the last stages of sleep and remembering those dreams. If you wanted to talk on that at all.
So with REM sleep, there are 5 cycles that come and go and intermingled with N2 or light sleep. And that's when we dream. And during that time, the body is atonic. In other words, nothing's moving except for the eyes. And that's where you get rapid eye movement, REM. And in our patients, our limbic systems don't cooperate sometimes, and so we'll have involuntary movements. People will sit up in bed, they'll put their hands over their head, they'll be shaking, they'll be talking in their sleep. And that's disruptive, but it's a sign of pathology. And it's something we need to do about it. I've had several patients show us movie videos of somebody totally asleep, but sitting up in bed and talking and putting the arms over their head. And so that's disordered sleep. And that kind of works into sleepwalking, in which the person is not conscious, but the limbic system and the sleep cycle has them walking around doing something for which they'll never remember what they did. And it can be hazardous. Rachel?
And then the other component that we wanted to cover, which we've talked about a little bit in regards to the hypothalamus and pituitary, but patients and watchers had been interested in the areas of the brain that are affected by sleep.
So sleep involves quieting of the active brain, the cerebrum. It involves, it's an evolutionary process that came to us because we need restorative sleep. As I said before, we have to rinse the brain, and then REM sleep is a little less defined, but in studies that voided REM sleep, people began to have neurodegenerative disorders. On the other hand, physiologically, it's amazing to know that if you don't get proper sleep, you're going to upregulate your pro-inflammatory cytokines, especially through nuclear kappa beta, which is a very potent proteolytic enzyme which activates all the pro-inflammatory cytokines. And so you have a brain on fire, more or less. It also affects weight, because it affects hormones called ghrelin and leptin. So if you're not sleeping properly, it's very hard to lose weight. You may gain weight involuntarily because there's hormonal shifts without sleep. But I think the most important thing, of course, is our trying to understand what are proper amounts of sleep for our patients. And our patients have many different examples of how they sleep, how they don't sleep. And there's a term called hypersomnia, meaning you're sleeping 12, 16, 18 hours a day. Of course, everybody knows what insomnia is. But we're after quality sleep, and there are certain medications that help that. And unfortunately, we can't be specific about that because I know we have a lot of viewers, and many are JSC patients, and we can talk to them, but we can't just prescribe medication. We can talk in generalities about some herbs and maybe some antihistamines. But there are a select number of drugs, not named Ambien, okay? Not named Ambien, which promote deeper sleep. And so we become fairly skilled in that. We're trying to learn to use as many of these drugs that are not habituating and which don't cause morning hangover, but which promote deeper sleep. And that's always our goal.
So let's get to some of the questions that you guys have sent us that we didn't touch on, I don't think, last time. One of them was asking why we ask for sleep studies. So the sleep study, a lot of times we'll ask patients to look into this if we are asking some of those common sleep questions, such as, are you having trouble staying asleep, or asking a partner or a spouse, are you noticing the patient stop breathing or choking or coughing or waking themselves up with snoring? And this makes us concerned that there could be a possible apnea playing a role. Identifying and diagnosing that is done with the sleep study, which is at this point with insurance coverage either done in the home or in a sleep center. We find that the at-home sleep studies are not necessarily as detailed as we'd like them to be. Sometimes our hands are tied if insurance will only allow for a home sleep study. But the in-clinic sleep studies are a little bit more detailed. And what we're looking at is different types of apnea. So we know that there are, obstructive sleep apnea, which people are more familiar with. So you think of a broader based tongue that kind of collapses back, blocking the airway, a thicker, neck or overweight individual, blocked sinuses, whatever the case may be. And that's an actual obstruction of airway for them to get oxygen through the night and allow them to sleep soundly. The other type of apnea is central sleep apnea, which both of us will talk about a little bit more. And this involves a little bit more of the nervous system, and it's difficult to pick up on a home sleep study. The other component is that there are anatomic versus functional limitations to or causations of apnea, all of which we'd like to find out or discover through a sleep study, because unfortunately we still need some of those diagnosis codes from insurance, so proving that the patient has disordered sleep, whether it's periodic limb movement or classic, apnea, and then being able to get them a CPAP device or mouth guard or otherwise to help them sleep is important. But Dr. Jemsek, do you want to talk about central sleep apnea a little bit more?
Well, central sleep apnea is, when you read about it, nobody talks about Lyme borreliosis, but we see it probably more commonly with this disorder than anyone else. And it's sneaky, and we do need a sleep study to document that, because the patient will end up with a BiPAP regardless, or a CPAP. Now, here's the thing about the Lyme borreliosis population. Rachel mentioned the physiognomy of the classic patient who is got a short neck, is stout, has an anatomical issue with the airway. But guess what? In our patient population, we have something known as hyperpharyngeal dysfunction, so that people have trouble swallowing. That's part of our initial evaluation. And so why do they have trouble swallowing? Well, sometimes we'll see a flaccid throat, so that there's no reaction, there's no gag. And guess what happens at night? The tongue collapses normally, but there's no natural clearing of the saliva, and there's no motility of the hypopharynx. And so people who are thin or skinny and long necks, they can still have sleep apnea. And the other side of that is hyperactive, a hyperactive gag reflex where it's spastic. So if you do an evaluation of the throat and you put a tongue blade there, it'll go into spasm. And of course, if you have spasm, that's going to cause occlusion of the airway as well. So one of the two, and that's why we see so much sleep apnea in our patient population, and we're clear to make that, we make that clear to the patient. And a lot of our patients are on BiPAP or CPAP for that reason.
Yeah, and just to clarify, CPAP and BiPAP is just a different distribution of, oxygen or forced air. And so it's helping the patient, get that oxygen just in different ways, essentially. Another question that we got from you guys, someone wrote in saying, I've been on maintenance for 4 years now. I fall asleep, but in the mornings, I just don't feel rested. Is that a sign that I'm starting to relapse? We don't think that that's necessarily a sign of a patient relapsing. Again, with that type of situation, we would go back and assess the efficiency of that person's sleep. So if they're sleeping through the night, but they're waking up after 8 hours and they're feeling exhausted, something's not right. Whether they're not getting into the delta or deep sleep for an efficient period of time or length of time, are they snoring? Are they getting up to go to the bathroom? And even though it's a short period of time, it's still disrupting them. Are they getting vivid dreams? So reassessment of, the sleep with those detailed questions would be how we'd approach that. The other thing that we look into, with a physical exam as well as a good workup is making sure that from a physical exam standpoint, there's no findings of relapse, such as, for example, hepatomegaly or enlarged liver indicating a resurgence of babesiosis. We also look into lab studies to make sure there are no outliers in regards to deficiencies of vitamins or other reasons why they might be fatigued in the morning that we couldn't blame on sleep. But that would be, a further evaluation. Another question that you guys asked was, how many hours of sleep does someone during treatment really need? I'm on IV right now, and there are times when I sleep too much or sleep less. It's very inconsistent. Dr. Jemsek wanted to touch on this in regards to hypersomnolence, so patients sleeping 18 plus hours a night versus patients that have insomnia, so little to no sleep, as well as dysomnia, non-circadian 24, and then the inverted adrenal axis.
Oh, wow.
You're welcome.
Oh, wow. Let's go back with the inverted adrenal axis. So you have to understand this disease swarms over our body, swarms over our brain, and that includes the adrenal axis. And so if somebody comes to life at 10 o'clock at night and then can't get to sleep, there's a good chance, and we measure this by doing salivary cortisol measurements, there's a good chance they have more cortisol at night than they should. And there's not much we can do about that, quite honestly. So they're very sluggish in the morning. In the morning, the cortisol should be high, should be here, and then it should drift down through the rest of the day, and that's nighttime. Okay, so, but in our patients, it's the other way. And we can't do much about that, honestly. People have to be in a loving environment to have a situation where people tolerate our patients' schedule, sleep schedule, if you will. And so the inverted adrenal axis is very important. Non-circadian rhythm, non-24 circadian rhythm is also present. This has to do with resetting. So when it gets dark, instead of setting out melatonin and getting into a sleep stage, our patients don't do this at 10 o'clock or 11 o'clock or 12 o'clock. They may do it at 4 in the morning. And this is a common pattern. Again, you have to be in a loving environment to tolerate this. So if they go to bed at 4 and they get up at 2 the next afternoon, that's their life, and we work around it. We can't change that until we treat the infections. And some have what I call ratchet non-24 circadian rhythm. So they'll go to bed at 1 o'clock for a couple nights, and then 3 o'clock for a couple nights, and 5 o'clock, and it's just this ratchet effect. And again, there's very little. So it's a mistake to try. First, you check the cortisol, see what's going on with that. But it's a mistake to try to medicate those people until you've cleared the infections. But again, you have to be in a loving, giving environment to allow somebody to go to bed at 5 in the morning, wake up 3 in the afternoon, and have all kinds of bizarre schedules. But it does happen with this illness.
Yeah, and again, I think, Dr. Jemsek mentioned this, but a key component is allowing that individual's brain to heal. So, purging the infection and then allowing that brain tissue to heal so that they can kind of slowly get back into a normal circadian rhythm. We do see that happen over time, but kind of pushing the body to go into a normal circadian rhythm when they're full of inflammation and infection is just like pushing a boulder uphill. Another great question that you guys sent in was, do you do anything for vivid dreams or night terrors or nightmares? This is a question we get a lot. I get from my patients too, and I ask patients this every time I do an exam or an office visit with them, and it's, are you having vivid dreams or nightmares? But the important part of that is, are you having vivid dreams or nightmares that you remember upon waking? So, all of us dream. Most of the time we don't remember those dreams. The problem with vivid dreams and nightmares, obviously we don't want patients to be, scared. Night terrors can be a real thing and can be provocative in regards to inflammation and pain and keeping them awake if they're woken from a night terror. But the other component is that if you have, vivid dreams that you remember, or you feel like you're really active in those dreams, it's keeping you from getting into some of those different phases of sleep. So sometimes we'll utilize a specific medication, which I won't mention, but a specific medication that helps to essentially calm that dream center down so that patients are not having as many vivid dreams, which allows them to get deeper sleep.
Let me continue with that and just expand on that a little bit. So we're dealing with a tortured brain. We're dealing with a brain that's sensitized. The activating neurotransmitters include things like histamine, norepinephrine, and glutamate. And they all have different manifestations, but if you're having night terrors, the medication that we use blocks the adherence or the attachment of the neurotransmitter norepinephrine to the synapses, and so therefore that alleviates the problem. There are a couple of different medications that we use for that. Other activating hormones include histamine, so everybody's onto histamine these days, and mast cell. And so we'll often use an antihistamine to try to see if we don't have a obvious night terror situation or a hyperadrenaline situation. Also with the adrenaline situation, you'll wake up and you're terrorized. Your heart will be racing, your heart will be pounding, you'll be panicked, and you wake up, and for no good reason, with or without a dream. And then glutamate, which Rachel can expand on as well, is a very common neurotransmitter. It interchanges with glutamine and GABA, but it's very essential to life functions. It's an activating neurotransmitter, and it is kind of like keeps us awake and busy brain. We call it busy brain. So you're not terrorized, and antihistamines haven't had an effect, but you have a busy brain. So glutamate has receptors. Again, we're dealing with a sensitized brain, which overreacts to the attachment. And Rachel can talk about a couple of amino acids that we use to help modify that.
Yeah, so busy brain is a common, kind of catchphrase for our patients. It's like, I just can't shut my brain off, whether that means in the middle of the night or initiating sleep or falling asleep. And so, Dr. Jemsek mentioned, the glutamate essentially causes that busy brain, so it's kind of activating and keeping you up. Two things that we have found to be helpful are L-theanine and taurine, which can help kind of calm those receptors down and allow patients to get into sleep or calm that busy brain. The next question that we had, which is for you, Dr. Jemsek, is it okay to take medications to fall asleep? What if I'd rather use marijuana-based products or CBD products?
So first of all, we try to use non-habituating medications, but oftentimes we have to use benzodiazepines. There are two pathways in our body that are regulatory for inhibition. One is the GABA cycle, and the other is the endocannabinoid cycle. So our body makes cannabis or cannabinoid products naturally, which have a sedating effect. And of course, there's numerous products available now on the market. And then of course we have benzodiazepines, which are helpful. Sometimes we use antihistamines. We'll try that first quite often, unless the patient tells us they've had a paradoxical effect to one of the antihistamines like Benadryl. But in terms of getting people into sleep, there are a lot of over-the-counter cocktails with valerian and passion flower and so forth and so on. There's so many cocktails out there for sleep, and they're reformulated, and a lot of them are very similar. And if they work, well, we're fine with that. We look at what the patient's taking. I don't like products that have 60 ingredients. I'm okay with products that I understand and know about that have 2 or 3 ingredients. But sleep initiation, obviously, is important, because if you're taking 2 to 3 hours to get to sleep, that's a dysfunctional sleep pattern. So we use benzos as a last resort. Benzodiazepines are things like, I'll just say Valium is one of them. It's not what we use ordinarily. But we are getting into using more CBD products, and there's some research suggesting that a derivative of the broad spectrum CBD, CBN, seems to have sleep properties, and there's some articles and research, probably not enough. But CBN has risen to prominence. And it's about 2.5% of the whole molecule, the broad spectrum CBD molecule. There's also CBC, CBG, so there are other derivatives. But this is derived and then expanded and sold as CBN. CBN, I've seen it mixed with CBD and THC. So we definitely depend on the CBD products. I'll use CBD to help with anxiety. I'll try to spare the benzodiazepines in that way, and it works fairly often. And for sleep, we'll do CBN, and we'll titrate it, and we'll do little different cocktails with off-label medications, sometimes with antihistamines, sometimes with antiemetic or nausea drugs. And we have some interesting cocktails, and whatever it works as long as it's safe. If we have to use a diazepam, we have to use it because we're trying to get our patient better, and sleep is so critical. If you remember POEMS, I'm sure some of you know our acronym, POEMS. S stands for sleep. And if we can't get our patient into some kind of sleep pattern, we can't help them, we can't treat them. So that's an essential goal when we first see a patient. We're trying to stabilize the patient.
I wanted to bring this up. One of our prior JSC practitioners actually wrote in, Anne, who we miss dearly. She mentioned that glycine is also good for a busy brain. Similar to taurine, it's an inhibitory, calming amino acid. She's right, and can be used in chamomile tea. So that was a good recommendation, and she's part of the JSC family, even though we haven't got to see her in a while. Another question written in was, during stabilization phase, I've been sleeping a lot better, and therefore my symptoms have eased or calmed down. Should I start treatment anyway, or just stick with the stabilization? So this is a good question, and I know we've gotten this question in other live streams as it pertains to pain or otherwise. But the stabilization phase is one of the most important parts of treatment. But at the end of the day, there's still infection that needs to be taken care of. And so there's compensatory mechanisms of stabilizing sleep, pain, gut, etc. But that'll only work for so long. And so yes, you do still need to treat, even though it feels nice to be stabilized and sleeping well.
Yeah, can I just make a comment?
Yeah.
So a lot of our patients will come in after the stabilization phase, and they say, "Well, I feel so much better," and or no, after we start just an induction program. Many of you at JSC know we start with a very simple induction program for 2 or 3 cycles, and we see the patient after that. But prior to that, they've been stabilized, and they say, "I feel so much better," and in part we're inhibiting some of the organisms, reducing the immune response, and therefore lowering the inflammatory quotient, if you will. And we've done that by stabilization. We've done that by eliminating gluten, putting in a few tier 1 antioxidants, and asking them to either passively or actively sweat, do range of motion, lymphatic massage, et cetera, et cetera. But we know that if a patient's better after induction, it's not the drugs that we're using because we're just in the initial phase. It's the fact that they've stabilized and they've changed their lifestyle. And often that lifestyle will persist for the rest of their life, because they've learned how to deal with inflammation. And we provide them with other means to engage in detoxification, other antioxidants, other activities as time goes on. But when someone comes in after just taking 2 or 3 rounds of our initial phase and say, "I feel so much better," I don't credit the medication. I credit the fact that they've changed their lifestyle and they're using a few herbal supplements as antioxidants and so forth.
So the next question is, why does everything hurt the next day if I go to bed late, even if I get 9 hours of sleep?
Well, it depends whether you went to bed in pain in the first place and whether you really had a restful sleep. I think it boils down to that. I think those are the questions. And what can we do to help with pain if somebody has constant pain? Well, I tend to go with herbals, anti-inflammatory herbals such as curcumin, fish oil, and vitamin C. I like to use topical CBD if there are specific joints that are bothering someone. Again, we need to know if they're restless as well. But we try to get the patient in a pain-free state. We do not prescribe narcotics, but we do use a herbal approach, which tends to work most of the time. Sometimes we use a muscle relaxant, which is fine, and some of these things are off-label. Some of the muscle relaxants promote serotonin in the brain, and again, we have off-label applications that we try to go to first. We're not excited about giving somebody a non-steroidal anti-inflammatory medication And we're certainly not excited about giving anyone a Schedule 3 or Schedule 2 pain medication.
I think another component of that too that we touched on in the beginning of this conversation is the buildup of toxicity when patients are sleeping, and that contributing to pain, in addition to the fact that Dr. Jemsek discussed that there are studies that show that if patients are not sleeping or not getting into some of those deeper phases of sleep, it does trigger the inflammatory pathway that can cause them to wake up in pain. But again, to your point, a lot of the question needs to be, are you going to sleep in pain or are you just waking up in pain? So breaking down, that a little further is important. The next question that we want to go over is somebody wrote in saying that they just got diagnosed with Lyme and they have not experienced sleep disorders yet. Should I expect that symptom soon? Not all of our patients end up getting issues with sleep. I would say that a vast majority of them do, and a lot of that is just based on the neurotransmitters that are involved, the brain being involved with Lyme and becoming infected. But we get some, lucky patients that I would say maybe less than 20% that don't end up having, sleep issues, which is fantastic. But I would say that as patients go through different phases of treatment, there is a likelihood that sleep in some form will be affected. Let's see.
Yeah, I think Rachel makes an excellent point about the upregulation of pro-inflammatory cytokines during sleep. So it's unfair, but if you don't sleep well, you're triggering a pro-inflammatory cytokine cascade, and you're going to be more inflamed, and that's going to have other metabolic consequences as well. Also, articles suggesting that poor sleep predisposes to depression. Obviously, it predisposes to mood disorders, memory, and I talked earlier about phase 3 or N3, with cleansing the toxins that the brain produces. So there are very many, just the more we talk about it, the more important sleep becomes as we learn more and more. And these are articles that are written 20 years ago and more recently as well. But I tell patients commonly, as we go through POEMS, the acronym POEMS, I tell people, look, if you can't sleep, I can't help you. We have to get you sleeping. I can't start therapy until I know you're getting some sleep. And so, we'll try conservative methods. We'll use all the tools available to us. And more or less we're successful. Occasionally we need a sleep study just to document that they do have sleep apnea so that they can be titrated. And more importantly, whether they have central apnea. Because I would say that Lyme borreliosis is the leading cause of central apnea in our world.
Another excellent question is, will your body stop making melatonin if you take a nightly supplement for a long period of time? Dr. Jemsek?
Melatonin is important in the sleep cycle, and it's produced by the pineal gland, which is in the back of the brain. And it does work in a pathway that reduces orexin and promotes sleep. If you take supplemental melatonin, I think there's a myth that the more you take, the better you do. And that's not true. Articles suggest that 5 milligrams at night is probably the maximum dose. And they also suggest that if you take it habitually, you're going to get what's called tachyphylaxis, which is intolerance to that drug. You'll need more melatonin, and that more melatonin won't necessarily be effective. So it's not the worst idea to rotate some of your cocktails if they include melatonin. And I would suggest that if you're going to use some of the herbals like passion flower, valerian, chamomile tea, things like that, I would rotate things around. Of course, if you need to be medicated with subscription medications, that's fine. You can still use melatonin and the herbals. So we commonly work with cocktails, and we'll go with whatever works for the patient, whatever's safe.
Yeah, and you may have mentioned this, and I just didn't catch it, but you know, the maximum of 6 months in regards to medications like that before starting to rotate them. And then, like Dr. Jemsek said, studies showing melatonin at 5 milligrams or less. Next question would be, why is the witching hour usually between 1 and 3 a.m.? And why do the medications I'm taking not work to help me sleep during that time? We touched on this a little bit in regards to the busy brain and glutamate activation. The other possibility is histamine. You know, again, with the sensitized brain, as you go through the night, you're getting a brain that's kind of turning on and then having trouble shutting off again. And so a lot of times that 1 to 3 a.m. is part of that phase of sleep. Dr. Jemsek, anything else on the witching hour?
No, I think you pretty much covered it, but that's unfortunate because, again, the delta sleep occurs in the first 4 hours of an 8-hour cycle. So theoretically, now, a lot of our patients don't have 8-hour cycles. But in a classic sleep pattern, you're going to see delta sleep in the first 4 hours after stage 1 and stage 2, and 1 and N2. And you're going to see delta sleep where the brain is absolutely quiet, where the veins are dilated, there's interchange with the spinal fluid. And we need about 20% of our sleep to be that, and it occurs in the first portion of the sleep. So if you're having a witching hour 1 to 3, you're pretty much not rinsing the brain. And that may be either a excitatory neurotransmitter such as glutamate or histamine. And then if you're waking up in terror, of course, that's norepinephrine. And so you need to look at your medication profile and see what you can do to calm the brain and convey that to your doctor if you have a particular habit of waking up early in the morning.
I wanted to circle back to sleep apnea. One of you wrote in asking about intolerability to the sleep mask, which I think is a good question. I've seen them. My father-in-law had to start wearing one, and I was like, that looks like a torture device. So I think it's a good question. They've come a long way with the CPAP masks. So that's one thing. So looking into different possibilities within the mask realm. So they have the like nasal pillow that also has humidified air going through. They have like the Darth Vader huge mask, which hopefully you don't have to try. And then the other things to look into are more anatomic, right? You know, could you simply have your bed a little bit more propped up so you're opening up your airway, maybe looking into where the obstruction is, if it's nasal, and, you know, having a procedure opening up, you know, in that regard. So there's different ways of, you know, addressing sleep apnea. The final answer doesn't just have to be a CPAP or BiPAP mask. Another question was asking us to touch on the moon cycles and how they affect sleep with an inflamed brain.
So the full moon. I'm here to say the full moon is real. We have atmospheric changes of 1 or 2 millimeters, and in our patient population, that's enough to set off their autonomic nervous system, and in some cases may affect sleep as well. But it's a repetitive complaint and revelation by our patients, and but they're afraid to tell anybody that, when there's a full moon, I have a really rough time. I get very irritable, angry, I can't sleep, I ache, I burn, I can't regulate my temperature, and it's just amazing, but it's real. And same thing with weather changes, barometric changes. Our patients are so sensitized, and it may affect their sleep as well because the autonomic nervous system is sensitized, and it's irrational. And so it's affected by barometric pressure because it's overreacting or underreacting in that sense.
Another question is asking if it's possible to be sleeping too much. I could sleep 21 hours a day some weeks. This is, a common question with our patients. You know, the short answer is no. You know, in certain phases of treatment, your brain is super inflamed, you're really sick, your body's processing a lot in the middle of these really complex treatment protocols, and there might be certain weeks or days that you need an exorbitant amount of sleep. We know that's difficult in regards to basic life functioning like work or being with family members, but it's important to nurture your body. So if your body is telling you that it needs sleep, you need to sleep. This goes for naps too, which we haven't touched on, but we might want to. You know, some of our patients will ask, you know, how much are you sleeping at nighttime? Are you napping? How long are you napping? And we'll sometimes ask, are you getting restored sleep for either of those? So sometimes patients will say they feel more rested after a nap versus after a nighttime of sleep. Dr. Jemsek, do you want to talk about the naps and the duration of naps a little bit?
So a short nap doesn't really get you into delta sleep and doesn't help much, and you can still get to some sort of semblance of normality when you go to sleep. However, you take a deeper nap for a couple hours, you get into deep sleep, your brain recalculates and you're going to have trouble sleeping that night. I think it's that simple. We don't, and some people tell us I just can't nap, or when I nap it doesn't help, and there's a reason for that. We're very lenient about the sleep patterns because we know how sick our patients are and how the hypothalamic pituitary axis has been affected. Sleep is a very complex process, and what we have is an inflamed brain with a lot of disturbed routes, communication, and transmitter confusion. So we're very lenient about sleeping excessively as long as somebody's there to help them get up and take their medicine. On the other hand, insomnia can be extraordinarily difficult, and maybe you should get into that a little bit. Insomnia.
The treatment of insomnia, or
just the incidents that we see in our population and how we address it.
yeah, I mean, insomnia, you know, is very common, and again, it's the difficulty falling into sleep and getting any number of hours of sleep, you know, dysomnia or disordered sleep, and then hypersomnia. Dr. Jemsek and I talked about this yesterday, and we were trying to figure out what the, you know, proportion or percentage is, and I think that, you know, it's maybe pretty equal between the insomniacs and the hypersomnolent individuals. You know, again, with the insomnia, you're looking at, you know, why is your brain not shutting off? Why are you not able to fall into sleep? And how could we aid in calming the brain down to achieve that? You know, similarly with like a, you know, hypersomnolent patient, again, the brain might need that much sleep, and so we're not going to, you know, push against that too much if that's what is needed. One final question, because we're getting towards the end of our time here. People have asked about prescriptions and supplements for sleep, and we won't touch on the specific names of the different prescribed sleep aids that we use here at Jemsek Specialty Clinic, but many of you have asked about how to safely come off some of these medications, and also, is it safe to just continue some of these medications? You know, Dr. Jemsek and I always want to avoid habitual use of meds. So if we're seeing patients increasing the dose, you know, that's, you know, not the point, and we want to make sure that that's not becoming a problem for that individual. We have a lot of patients that stay on the same very low dose of these prescription medications for a long period of time, and then when their brain is healed up, they're able to come off them pretty easily. But I think for the most part, there are sleep meds that might be needed for longer stretches of time.
Yeah, I agree. So in terms of the sleep initiation medications, we do have some category of drugs that are habituating, but sometimes it's necessary, and patients depend on that to get to sleep, and we're all about getting into sleep and getting the patient better. We'll say, let's fight another day and taper those drugs. And I'm talking about the benzodiazepines primarily. The cannabis products, which I mentioned earlier, are an alternative, and then you can use a cocktail with some herbs and other things to diminish or spare the benzodiazepines. As far as the delta-producing medications, none of them are habituating, and we can use one or more at a time, and the whole goal is to get you into sleep. Again, we look at two phases from our sort of simple point of view. We want you into sleep in a reasonable time, and we want you into deep sleep. And we have to identify whether there's an issue of restlessness, nocturia, getting up at night to go to the bathroom, apnea, pain issues, and so forth. And so we concentrate on those first, but if those are absent, then we have to use medication to get into sleep, and that's what we do.
So these were all great sets of questions. We really appreciate everyone sending them in and allowing us to answer some of these common problems that everyone unfortunately has to deal with. Again, I think just recapping, approaching sleep, from a stepped back view. So looking at, the questions of, is this trouble falling asleep or staying asleep? What are the disruptions? How can we approach, then fixing those problems? So yeah, Dr. Jemsek and I have loved talking to you guys today. We'll be back in a couple of weeks with a new topic, and we can't wait.
Thank you, Rachel. Wonderful job. I tell my patients sleep is the number one herb for you, the number one remedy. It's more important than just about anything else. And so we focus very much on sleep. It's been a pleasure speaking with you. We're so proud we've done 25 live streams. And I'm so proud to work with Rachel and some of my other colleagues in delivering these messages. God bless.